Welcome to ATCM, the Emergency Medicine Channel. I am Dr. Cecil, ERPG.
Hi, I am Dr. Manoj Pratapan, Professor of Ophthalmology and Glaucoma Consultant at the Institute of Medical Sciences, Kochi.
Shall we start, sir?
Please do.
A 64-year-old male presented to ER with complaints of left eye pain and left-sided headache since one day. On initial 10-second assessment, patient was conscious and oriented. Airway was patent, no pooling of secretions. Breathing, respiratory rate was 16 per minute. Saturation 98% on room air. Air entry bilateral equal. Circulation, BP was 150/90 millimeters of mercury. Pulse rate was 90 per minute. All peripheral pulsations equally felt. Disability, GCS was 15/15. He was having a pain score of 8/10. So at that time, we had given an injection PCM 1 gram IV stat. Exposure, he was afebrile. We have reassessed the pain score and it was reduced to 2/10. Coming to history, a 64-year-old male, known case of diabetes and left eye cataract, status post PCIOL, 2 to 3 months back.
Post cataract surgery, no?
Post cataract surgery, 2 to 3 months back.
Okay.
He was having complaints of left-sided headache associated with left eye pain since 1 day. It was associated with redness and watering. He also gives complaints of decreased vision in the same eye. He was initially shown in a nearby hospital and was diagnosed as neovascular glaucoma, and he was taken anti-VEGF injection 1 day back from that hospital. Since he was having severe pain, he was referred here. No history of any trauma, any foreign body sensation, any purulent discharge. On examination, patient was conscious oriented.
So, just to get the history straight, so this is a patient, elderly patient, diabetic patient, presented with an acute onset of redness and eye pain of one side, left side.
Left side.
Okay. Patient is post cataract surgery, post intravital injection of 1 day duration. Cataract surgery 3 months and 1 day back VEGF injection. On topical drops.
On topical drops, Timolol.
Only on Timolol. No cycloplegic or steroid or nothing. Antibiotic also not there. Unlikely, because usually after injection there will be few more medications which are given, like a antibiotic. Okay, and for the NVG maybe a steroid must have also been there. All right. So when a patient comes to you with acute onset of eye pain, what are the possibilities? What are the differential diagnosis?
Conjunctivitis.
Conjunctivitis is not a painful condition. There may be some discomfort, because conjunctivitis is pain sensitive. Inflammation of a pain sensitive tissue will produce some amount of discomfort, but it is not a painful condition. Unlike keratitis. Keratitis is a painful condition. Keratitis means inflammation of cornea. Sometimes some of the viruses can cause keratitis as well along with conjunctivitis. We call it keratoconjunctivitis. When that occurs, there will be eye pain. Otherwise, normal conjunctivitis is usually, there will be some discomfort but not very painful, unless it's a very severe fulminant conjunctivitis. Other DDs?
Iritis.
Yes, iritis is something that comes with eye pain, but it is not an acute sudden onset. It is mostly an acute onset. Maybe within few days they will have a symptom. Some iritis can be of chronic nature, so these patients keep having the symptoms again, recurring symptoms, but sometimes they can present as acute iritis when they present with 2-3 days of onset of eye pain. Anything else?
Any trauma?
Okay, trauma, they will come with the history of trauma directly, and what happens in the eye which produces eye pain.
Endophthalmitis.
Okay. So trauma related, what can happen? Trauma, if it's a penetrating, there are two types of trauma. One is a blunt force injury, other one is a sharp injury. So sharp injuries usually produces either something like an abrasion or a penetrating injury. So that definitely is painful. Whereas a blunt force injury, there may be some contusion pain, but there could be intraocular damage which can occur along with the trauma, which later on may lead to other problems. So there may be a subluxation of the lens, which itself is not painful, but the subluxation may induce an acute angle closure or something which can be painful. There may be a rhegma in the retina which may later on lead to a detachment of the retina producing blindness. There may be dense vitreous hemorrhage, and this vitreous hemorrhage over time may produce a glaucoma. So many ways eye pain can happen in trauma. Inflammation can be there, so traumatic iritis may be there, that can also lead to eye pain. Okay, you said endophthalmitis. Endophthalmitis, commonly you can have endophthalmitis after, say, an incisional surgery. That's called as exogenous endophthalmitis. The wound can get infected and then the bacteria can enter inside the eye and produce endophthalmitis. That is a painful condition. The other type of endophthalmitis is endogenous endophthalmitis. We may be seeing more over here because it's a tertiary center where the infection actually originates from elsewhere in the body and then through the blood, through septicemia, it reaches the eye and infects the eye. These are also emergencies. Any other disease? Acute IOP. So whenever somebody has a sudden rise in intraocular pressure, that can produce eye pain. This commonest is acute angle closure glaucoma. There could be like NVG, certain cases of uveitic glaucomas. These can all produce sudden rise in pressure and that can lead to eye pain. Chronic glaucomas like primary open glaucoma or other primary angle closure glaucomas, they do not have eye pain. Acute rise in spike in pressure only produces eye pain. Anything else? Radhika?
So, acute could be scleritis, episcleritis.
Yes, scleritis is also a painful condition. Again, not a sudden onset, it can present as an acute onset of eye pain and redness. I think most of the cause of eye pain we have discussed. Maybe even migraine can present as an eye pain, okay, without redness. It can even present with redness also. So migraine is a possibility.
Orbital cellulitis.
Orbital cellulitis, yes. Orbital cellulitis is painful. Some conditions like say lid infection, like a hodiolam, can also be painful, but they are not very severe. So they come with the swelling of the lids rather than eye pain. Eye pain also is there. Yeah. Okay, proceed.
On examination, conscious oriented, no pallor ictus cyanosis, clubbing lymphadenopathy, local examination of left eye, there was redness, watering and mild eyelid edema. Corneal edema was present, hazy cornea was there.
Okay, so eye examination usually starts with visual acuity. So vision is, eye's main purpose is vision, and we should know what the vision is of the patient. So yeah, what was the vision?
Right eye was 6/36.
Yeah, so visual acuity was 6/36 the right eye and
left eye 1/60.
Oh, very poor vision. Okay, 1/60 means the patient can only read the first letter of the Snellen's chart at a distance of 1 meter. That's what it means. So if patient is seated at 6 meters away from the Snellen's chart and they are not able to see the first line, bring the patient closer to the Snellen's chart up to 1 meter, and then they are seeing, we call it 1/60. Okay.
Then it was stony.
Local examination of eye, you can say. What are the findings you saw?
There was redness, watering.
Okay, redness are two types: circumcorneal congestion and superficial congestion. Superficial or diffuse congestion. This diffuse congestion is what you commonly see in conjunctivitis or chemical injury into the eye, foreign body in the eye. This can all produce superficial congestion. Diffuse can superficial, mostly diffuse. You can have localized superficial congestion as well, say foreign body located in one place, or a small traumatic aberration of conjunctiva in one place can produce a localized superficial congestion also. The other one is circumcorneal congestion. Circumcorneal congestion is also called as deep ciliary congestion because these blood vessels originate from the ciliary circulation. So they are suggestive of high acute rise in intraocular pressure or uveitis. So these are two conditions where you have circumcorneal congestion. Most commonly it is uveitis. The second one is acute rise in intraocular pressure. Okay, so this patient had what type of circumcorneal congestion?
Actually,
both diffuse and diffuse and congestion. Okay.
Mild eyelid edema was also there.
Okay.
My cornea was slightly hazy.
Okay, so corneal haziness, again, it's not possible to pick up what type of haziness it is with torchlight. With a slit lamp examination, we will know whether it is a microcystic corneal edema, whether it is stromal edema, or is it an opacity. Okay, so all of this will appear hazy. So a nummular corneal opacity will also appear hazy. But if it's a diffuse and same status all over the cornea, it is likely to be corneal edema than opacity. The corneal opacity is usually in one particular location, whereas edema is all over. So if it's a generalized diffuse haziness, it is usually edema, and the edema can be either epithelial edema or stromal edema. Okay.
And pupils were mid dilated.
So after the cornea, comes to the anterior chamber. So again here, since we are thinking about sudden rise in pressure, one of the commonest mechanism is angle closure glaucoma, and one of the signs you can see is a shallow anterior chamber. And to demonstrate shallow entry chamber, you have to throw the light from the obliquely from the side and observe for a crescent shadow into the nasal peripheral iris. If that crescent shadow is much broader, then it's a shallow chamber. If it's a normal chamber depth, it's a very small crescent, and sometimes in a deep chamber you don't see any shadow. So that is one important sign that you have to look at. Other thing is that sometimes the anterior chamber may be filled with blood. That's called as hyphema. Especially if the patient has, if you are suspecting something like a neovascular glaucoma or a traumatic eye pain, then we should look at hyphema. The other thing is cells and flare in the anterior chamber, which you cannot pick up with torchlight. You will need a slit lamp for doing that. Okay, now we can talk about iris.
Pupils was mid-dilated.
The pupil was mid-dilated. That is pharmacological dilated, or it was?
No, we have not been any much dilated.
Fine. Okay, so you don't see a direct reflex as well as concentric reflex in that eye. And what about the concentric reflex of the other eye?
Right eye was normal.
Okay, so there are two types of light reflex. One is direct reflex, other is concentric reflex. So direct reflex of the right eye means you are shining the torch in the right eye and examining the pupil of the right eye. Okay, it indicates that optic nerve is the afferent and efferent is the third nerve. Okay, when you show light in the left eye and observe the right eye pupil reaction, that is called as consensual or indirect reflex of the right eye. The examined eye is the eye. So consensual reflex of right eye means eye that we are looking at is right eye, whereas we are putting the torch in the left eye. This consensual reflex is indicative of left optic nerve and right third nerve. Right direct means right optic nerve and right third nerve. Right consensual means left optic nerve and right third nerve. That's clear? So here, since it's a uniocular problem, we expect the consensual of the right eye to be affected. Okay, it cannot be normal. The right consensual and direct and indirect may be absent. It could be either because of a local problem, say the sphincter damage, or it could be pharmacologically dilated, or there is a neovascularization and the ectropy on UV has already occurred because of neovascular glaucoma. That is a local problem. So both direct and consensual. Consensual means you are throwing light in say this is the left eye we are talking about. So the right eye, and we did not observe construction of pupil in the left eye. So that is absent. Direct and consensual means it's a local problem or a third nerve palsy. Okay, in third nerve palsy also there is, because the direct may be the optic nerve may be intact, but third nerve is not bringing it. So third nerve palsy or local problem, that is what both direct and indirect when is affected, that is the meaning of it. Okay, what is next? Lens is pseudophakic, right?
Pseudophakic.
Pseudophakic lens. Okay.
It was stony hard.
Okay, digital tonometry is showing stony hard feeling. Yes, so that is indicative of one thing only, which is very high IOP, very high IOP. Even that IOP has to be somewhere about in the 50 or above. So usually that hardness changes in the late 40s. Before that, it is too difficult to pick it up with digital tonometry. Okay.
So we have from here we have given an ophthalmology consultation.
Okay. So with your eye examination, were you able to come to any sort of conclusion?
Acute raise in IOP.
Okay. So your diagnosis is it's a acute raise in IOP post intravitreal injection of Avastin, and all the patient has documented evidence of or a history of neovascular glaucoma. So this is neovascular glaucoma presenting with sudden, rise in pressure and eye pain. Okay. Okay, so in the ER, what can you do for the patient before the ophthalmologist comes there?
Pain management.
Pain management you have done. So pain management is with what do you give?
We give initially paracetamol, but
okay.
It was okay with that.
Okay, I think very severe eye pain, 8 out of 10. You could have probably given slightly more analgesia. Yeah, NSAID or even sometimes even tramadol we can give to lower the eye pain. And one important thing is you can start treatment before even ophthalmologist reaches. We don't want to waste any time in emergencies. So acute IOP is an emergency. What is an emergency? Because it's that can lead to a permanent damage, permanent disability if there is a delay in treatment. So the course of the patient's outcome is different when you treat them early and then treat them late. So in any acute IOPs, you can start anti-glaucoma medications then and there itself. So one thing you can give is intravenous mannitol, which is available for you, whereas the eye drops may not be there in the ER. So put a cannula, the blood pressure is normal, patient doesn't have any cardiac history, there is no anuria. Okay. Congestive cardiac failure is something you should be aware of. You should not give, and anuria is another place where you should not give mannitol. So we can give 100 ml of IV mannitol over say 10 to 15 minutes, and that should bring down the eye pressure, and the patient should feel better with that. All right. So then, what was the ophthalmologist interpretation?
On the left eye, the IOP was at that time 48 mm of mercury.
48. Okay.
So IV mannitol 100 ml stack was given. And
okay.
acetazolamide SR capsule
Okay.
250 mg QID was given.
Okay.
And brinzodium eye drops was also given, and it was reassessed after 30 minutes, but left eye it was only 46 millimeters of mercury at that time also, right eye 20.
Okay, so MVG may not really respond to topical or systemic medication, like unlike other glaucomas. So like I said the commonest cause of acute rising pressure is acute ankylosing glaucoma, which is slightly more responsive to treatment. Once you reduce the pressure and break the attack and put pilocarpine and reduce the pupil size, that episode is aborted, and we have time for the next intervention, that's the laser peripherotomy. We can take few days. Whereas some of these neovascular glaucomas don't respond to just topical medication alone. We have to go further. So it all depends upon the duration of onset of the disease. So some of those diseases present late, and those late presentations actually are resistant to treatment. So if you talk about neovascular glaucoma, we have the first stage of neovascularization means, it's a new vessel formation in the eye. Okay, what is abnormal new vessels? These are because of retinal ischemia. Conditions which produces retinal ischemia produces a chemical called as VEGF, and wherever VEGF causes and touches that area, new vessels are produced. And when there is a new vessels in the iris, we call it rubeosis iridis. When these new vessels are seen in the angle, that produces glaucoma. So neovascular angle is seen with the gonioscopy. So there may be a situation, the earliest stage of the situation, where there is neovascularization of the angle, but there is no glaucoma. It's an open angle stage of the disease where the new vessels are there in the angle and IOP has not yet gone up. That is the best stage where you can actually pick up the patient, and the best prognosis in that stage. You can reduce the neovascularization by giving an anti-VEGF injection and followed by pan-retinal photocoagulation, and then the patients do well. In the next stage, there is still open angles, there are new vessels in the angle, but IOP is high. Even this stage is okay. In this stage also, the same treatment if you had given, the pressures will come down, and then with this anti-VEGF effect kicks in, the new vessels will subside, and then the patient can be sometimes even off treatment. Without medicines itself, the pressures may be controlled, or maybe they may require 1 or 2 anti-glaucoma medications to get their eye pressure under control. Then the next stage, when at this stage, if we have failed to pick up this disease, or the patient has not got eye care, then there will be a synechial angle closure, where this fibrovascular membrane will contract and pulls the peripheral iris towards the angle and closing the angle. This is also a kind of angle closure glaucoma, but it's a synechial angle closure, not a pupillary block glaucoma. So earlier I said the acute angle closure glaucoma is a type of pupillary block glaucoma. We'll discuss on that later. So this is a synechial angle closure, and there is no role for laser peripheral iridotomy. And in this stage, probably this patient is in that stage where there is synechial closure. And in this stage, even if you give anti-glaucoma medications and systemic as well as topical, that may not bring down the pressure. So such situations, we need to go in for a surgical intervention called as trabeculectomy. So that's a filtering surgery where the pressure, the aqueous humor is diverted through the scleral wound into the subconjunctival space. So once that surgery is done, the pressures come down, the corneal clarity improves, and further additional treatment is done to prevent further neovascularization. So for that, already anti-VEGF is given for this patient. So that medicine will be effective for 3 to 4 weeks. In that time we have to do the surgery, and then after the surgery is done, once the cornea clears up, then we have to go for laser pan-retinal photocoagulation. Pan-retinal photocoagulation is basically ablation of the ischemic retina so that this VEGF is not further created. Yeah, sometimes this neovascular glaucoma is very aggressive, and our PRP may not be enough to control the neovascularization. So these patients may require further injections. Sometimes these new vessels may come and then block that ostium of the trabecular mesh, that trabeculectomy that we have done, and then the failure of trabeculectomy is also possible. In such situation, again the pressures may go up. So then the other option available is to put a glaucoma drainage device implant to reduce eye pressure. And then there is another option of diode laser cyclophotocoagulation, where we use a laser to ablate the aqueous producing ciliary processes. So that can also reduce the pressure. So if none of those works, then lastly we have this to reduce eye pressure. Okay. Anything else? Any?
He was eventually taken up for trabeculectomy.
Trabeculectomy. Yeah. Okay. So trabeculectomy followed by PRP, pan-retinal photocoagulation. Yeah. Because we have to address the root cause. The root cause is PDR, proliferative diabetic retinopathy. Okay. Any questions, Radhika? Or anybody else? What in ER can be done other than mannitol? You can also give acetazolamide. Acetazolamide IV is not available, I think, here in India. So tablet you can give. But many of these patients who have got acute IOP will have severe eye pain and they may have vomiting. So tablets and all, they may vomit out. That's a problem. Then topical eye drops also you can give. What we usually give is aqueous suppressants like beta blocker, alpha agonist, and carbonic anhydrase inhibitor. So timolol, brimonidine, and what is it? Brinzolamide or dorzolamide. Yeah. That's it. Okay. Thank you.